Hello, everyone. I'm Azim Latif from New York, and welcome back to our next session, which is on the tricuspid valve, the no longer forgotten valve. And we're really going to dive into tricuspid intervention. This is certainly one of the fastest growing area for us in our valve clinic. We're getting more and more patients, and the number of technologies and innovations in this area are growing at a rapid pace. And so, hopefully, in this next hour, we can cover most of these areas for you, take you a little bit through how we think about device selection, um, how imaging is the backbone to this, and also take you through a procedure of valve replacement in a didactic way. Today, I'm joined by an incredible panel of friends and experts, starting with Gagan Singh from UC Davis in Sacramento, Edwin Ho, my imaging partner from Monty, Mark Russo, our surgical colleague, also does a lot of transcatheter interventions from Robert Wood Johnson in New Jersey. And last but not least, I was saving the best for last, is Nadira Hamid. Nadira is really an expert in all things structural, especially on the imaging side, and is joining us from Minneapolis. So, guys, thanks for joining. It looks to be a great session. Appreciate you being here, and let's keep this engaging and fun for everybody watching. Please send us your questions. We'll try and address them after every presentation or at the end. And we're going to go dive right in. And we're going to start with Firaz, who's going to take us through really one of the important questions in tricuspid intervention is how do you match the right device for the right anatomy? So let's start Firaz's presentation.
Hello, everybody, and it's an honor to be with you all today, and I'm sorry it has to be virtual. I'll be discussing tricuspid valve intervention, what device for what anatomy. I hope my task is to make things simpler rather than complicated. I'm Faraz Zar. I'm one of the interventional cardiologists in Oregon Health and Science University in Portland, Oregon, and this is my disclosure slides. What we have learned from surgery is that repair is better. This is a meta-analysis showing that repairing the tricuspid valve is better than replacing it. However, there are multiple caveats into that. One, that those patient population that they were studied are younger compared to most of our tricuspid intervention that are transcatheter. Most tricuspid surgery is done in the setting of left-sided surgery. Rarely primary, secondary, or functional TR is performed. Endocarditis is the most common indication for isolated tricuspid surgery, and yet the mortality varied. However, it appears to be, from most reports, higher than someone would expect. And also, there is limitation for surgical repair in a way that those repair tend to fail with time, and to various degrees. In the United States, a couple of years ago, there was two devices. They were approved relatively simultaneously for repair and replacement, which put on the table the options of repairing and replacing to our treating physician as well as to our patients. And registry early on start predicting who will do well with repair versus replacement. This is, for example, a really extensive registry from TriValve registry looking at outcome after tricuspid tear that's showing that those who have a broader jet, wider jet with tether leaflet and tend to have significant residual TR. We have gotten better with time. However, those still are predictors for procedural failure, if you wish, or less than optimal results. On the other hand, TTVR is replacing the valve has been reproducible, predictable, and if you look at data from TriScend, almost all patients who got evoked valve has almost elimination of tricuspid regurgitation. And why the anatomy matter? The anatomy matters because the tricuspid valve is unique, it's large, it has not only the leaflet, but also the papillary muscle, the chordal attachment, and the annulus. And any device that has to rely on the leaflet has to deal with the complexity of those leaflets. Not all of them are tri-leaflet, some of them are bi-leaflet or even 4 leaflets. And this has been illustrated beautifully by Rebecca Hahn and teams, showing that there are multiple variation in tricuspid valve leaflets that makes repair a bit unpredictable. And if we go beyond the leaflet, to the papillary muscle of the subvalvular apparatus, also it gets even more and more complicated for those devices. So what do we actually currently do in repair? Those are the two devices that have been widely used: the TriClip as well as the Pascal Ace. And if you look at those two devices, yes, there are some design differences, but the concept is, you're going to capture leaflets on both sides and you're going to approximate them together. So those devices are heavily, heavily dependent on leaflet anatomy. And therefore, the results, whether you look at class 2TR or class TR-EFS, what is published, and TriLuminate, what is published, it does not eliminate TR. It decreases it, but there is a significant number of patients who will have residual tricuspid regurgitation. Therefore, some said, well, let's just forget about the leaflet. Why don't we deal with the annulus? And there are multiple devices that are designed to look at the annulus agnostic, of the leaflet. The idea is this is how the surgeon repaired the valve. Why not put an annuloplasty and constrict the annulus? The problem with that is there are multiple devices. The learning curve is steep, long procedural time. The RCA is closed, large annulus, and makes the reduction of TR suboptimal, and imaging can be challenging as well. Therefore, if we say, okay, now if we don't want to do repair, let's just do replacement, looking at the outcome of replacement. The predictable outcome of replacement is pretty much eliminating tricuspid regurgitation. However, this is the valve that is evoked, that is FDA approved. However, there is still some consideration for those valves in terms of high pacemaker rate, the impact of RV dysfunction, the patients being accepted is still, many patients are not being approved for those, and it need improvement in the delivery system, as well as the rate of halt and thrombosis remain unknown for those valves. Therefore, multiple valves are currently in the United States and Europe are in different stages of development, from early feasibility to pivotal trials, and there are at least 4 or 5 of those devices coming to the United States with pivotal trials. Some of those valves are dedicated for tricuspid. The Evoke and many other valves are initially designed for mitral, then switch to tricuspid, and those are examples of valves that are coming to pivotal trials in the U.S. that are designed specifically for the tricuspid valve, with multiple potential advantages of those valves. Now, what if we cannot see? This is a case that is difficult. There is leads, there's torrential TR, there is an annuloplasty ring, and in this case, visualization was not great. And this case was treated with the Intrepid valve, and as you can see, this valve, the concept of deployment is atrial through ventricular. You define where the brim is, and you deploy the valve. And in this case, we were able to achieve good results, despite the fact that we are not able to see the anatomy very well. Now, what would happen if we make the wrong choice? If we think the anatomy is suitable for repair, however, we were wrong. This is a case with a single leaflet detachment after great results in the first 24 hours. And in this case, we went back to the bench and we tried how would Evoke setting up a TIO device. And this is what we predicted based on the animal model. And we brought this patient and we treated with Evoke, entrapping the TIO device, in this case, anteriorly, with very good results. And if you see here, we got the results that we exactly predicted from the animal model. And we got this case published, and ever since there are multiple reports looking at what to do after failed TIR or facilitated TIR to proceed with TTVR. There are multiple technologies that are looking at removing the TIR devices and proceeding with TTVR afterward. And finally, what would happen if we got great results, like in this case? However, in follow-up, the results were not durable. This is a patient that a few months after TIR, there's recurrent residual TR. And in this case, we have turned this device into an SLD by lacerating it from lateral, and we went ahead and we deployed the TIO device. And to conclude, and I really encourage you to look at this paper that summarize what makes anatomy very suitable for repair and what makes it more suitable for replacement. And there is the wide range in the middle, in between. To summarize, it's important to understand the actual tricuspid valve anatomy, not just the echo images, the anatomical relationship to determine risk, and some of the risk profiles of those devices, whether they're leaflet, annular, or replacement, and be prepared. Sometimes repair, sometimes replacement, and sometimes a combination. Thank you very much.
Right. Thanks, Faraz. That was, as always, Faraz always lays it out very clearly. I don't have any questions from the audience for you guys yet. I don't know if anybody has any comments to make. If not, we'll move on. No, I'll ask a question then. Gagan, I mean, your approach to repair versus replacement, now that you have two technologies, I mean, just very briefly, how do you think about that?
Yeah, I mean, it's tough. I think it's institutional dependent and also operator and team dependent. And so I'm fortunate I have phenomenal imagers, as do you and as everybody else on the panel here. The main thing is whether I'm thinking TIO versus TTVR, is imaging optimal first. And if imaging is optimal, that really helps sway me towards one over the other. If I think imaging is good and I think I can get the patient down to tracer 1+, I will go towards TIO. If it doesn't look like I can get the patient down to tracer 1+, I might target TTVR. That's kind of the current algorithm that I use.
Okay, great. Thanks. Maybe we'll go on to the next speaker, and maybe Edwin and Mark, you guys are going to be presenting each a repair and a replacement case, but maybe you'll also, during the case, share with us a little bit your thoughts on why you choose one over the other and why you chose it in that patient. So let's start with Edwin. Edwin, I think you're going to be taking us step by step through a transcatheter tricuspid valve repair.
Yeah, absolutely. Okay, so as mentioned, I'm going to start with the repair side of things. You already heard a lot about what we mean by that, which is edge to edge. And we'll walk through really kind of a case, but I'll try to set up the background for that as well. Just trying to advance my slides here. Maybe if somebody can help with that. Okay, these are my disclosures. And we'll move on to the next slide. So this is the goal that you saw in the last talk. So when we're talking about repair, I'm focusing really on what's commercially available in terms of from an edge-to-edge point of view. Obviously, there's investigational technologies, but this will be the focus of really this talk. And in the United States right now, we only have TriClip that's commercially available. And as you heard earlier, what we're really trying to do is take the leaflets, approximate the edges, and convert what you see on the image on the left, where there's an actual coaptation gap, to the image on the right, where you actually have a length of coaptation at that part where you've placed the clip, but ideally in actually throughout the valve to really reduce the tricuspid regurgitation. Before we do the full case walkthrough, I do want to just go over some of the key imaging views. You heard that this is really an imaging and echocardiographically guided procedure. And so I just want to make sure we're all on the same page with everything that we're going to be looking at over the next couple of slides. So there's really two key views that we think about for these procedures. This is what we often will call this inflow-outflow biplane. And essentially what it's doing on that anatomic illustration you see on the left is we're generating a primary image plane that's approximately parallel to the septal leaflet. And then from there, we'll generate an orthogonal view that will then show us the septal leaflet and the opposing, whether it's the anterior or posterior leaflet, depending on what we're actually targeting at that time. The view, in addition to this, that's really helpful are our short axis views. And the short axis view we typically will get in the transgastric view. If we can just advance the slide here. And you've seen, again, example images of this. And essentially, this is when we're really looking at all the leaflets at once. So this in combination with those two views I showed on the prior slide really give us the geometric relationship of everything in the valve and where our device is located. This orientation, by the way, is flipped. So instead of how we drew the heart on the previous slide, you see the aortic valve here is actually down at 5 o'clock because we're looking from underneath the heart upwards. And then in terms of your comments about device and procedure selection, this is really what I'm focusing on when I'm looking at this type of view. I'm trying to understand the commissure lines, the commissure gaps, the chordal density, and geometrically trying to understand, can we oppose those leaflets to get a good result with the clip like you're seeing over there on the image on the right. So now we'll move forward and we'll talk about the key procedural steps. This is, oh, sorry, just a quick example of what we often will do during a case and what you'll see during this case example, which is using live 3D imaging and MPR. And the advantage of this is, as opposed to 2D imaging, we actually have all three of those views that I just showed you all at the same time, along with the 3D rendered view. So this just allows us to have all the information simultaneously. So as long as your imaging window allows for this, this is probably the best way to really see what you're doing at every step. So in terms of procedural steps, we'll advance onward. So this, just like you probably have heard on the mitral side, there's some very key steps in tricuspid repair that follow the same flow, whether you're doing multiple devices or single device. So essentially you set yourself up first in the right atrium, then your device gets inserted, steered down to the tricuspid valve. We'll spend a lot of time optimizing position and trajectory, as I'll show in the next couple slides. And then we'll orient the device itself. Then the last part is often the challenging part, but if you set yourself up well, that's what leads to success in many cases. And of course, we need to actually grasp the leaflets and then close the device to cause that coaptation. So we'll move on to the case now. So this is that first step I mentioned. So this is putting the guide in the right atrium. You can obviously do this in 2D imaging. Here again, this is our workflow in 3D imaging. Just to orient you, our 3D and short axis views usually have our aortic valve up at that 10, 11 o'clock position. So it's a little bit different than the true transgastric view, but the catheter movements are in line and match what we see on fluoroscopy. And here we're basically getting ourselves set up. So we really want our guide around the mid right atrium, because then we know we're in a free space, and then we'll be able to introduce our device. Moving on to the next step is going to be when we actually bring our device into view. This first example, I wanted to show what things can look like in 2D imaging. And this can still be helpful because in some situations, you won't see it very clearly on 3D. And at the end of the day, it's always about safety first and getting the procedure done in an efficacious way. And so at the end of the day, using the right imaging tool at the right step is really what's critical. And so here we're really tracking the tip of the device. We're watching on both fluoroscopy and here on echo biplane imaging, making sure that we're not interacting with any anatomy and getting ourselves pointed down at the valve. On this next image is again what we more typically do, which is focus on 3D imaging. So let's just advance the slide here. And so this is typically what we'll do because it's often much easier to follow this in 3D. I apologize for some of the flushing bubbles that you see. But if you try to exclude the bubbles from the image, essentially you can actually see on 3D very clearly as you're steering down, whether you're going up very laterally towards the wall, whether you're going towards the septum. And then using the NPR planes, we can also follow that tip and that view along very carefully. And that way we know we can get down towards the valve, again, in a really safe fashion. Moving on from here to our next image, we're going to really try to get our position and trajectory optimized. And this is why I tried to annotate this slide a little bit. So you see the red dots there, and that's essentially what I mean by the position. So we're really looking at the device itself and whether or not it's in the space where we want to actually implant it. So that's the leaflet pair that we want to target and at the right location. And then the red dotted line is what I mean by trajectory. And just like with the mitral valve, we really want to stay perpendicular to the level of that coaptation area so that when we're grabbing the leaflets, we're actually getting them symmetrically. So we'll spend a lot of time on this particular step to get everything really set up properly. So again, when we actually go to cross and grasp the leaflets, we'll have everything set up perfectly. My next slide here has a little bit of like a mental cheat sheet, I guess, in terms of when you're seeing something, what are we actually doing to optimize that? And essentially in this anterior posterior axis to actually just change the position in a pure just a position translation, we usually actually are moving the entire system, either advancing it in further or actually retracting it. We'll use what's called the F or the flex knob to actually affect both our AP trajectory and our position. So it'll create those yellow dotted lines. So if we wanted to move, one way or another, that's how we'll adjust how much F knob we have on. In the septolateral axis, it's a little bit different. So clockwise rotation of the guide is going to take us septally, but of course, the whole system is going to move. So the trajectory also changes slightly, and counterclockwise will do the opposite. And then we also have this SL knob that as you place more L on it, it's actually just going to translate the entire system towards the lateral annulus. Moving on to the next step of the procedure, once all of this is well aligned, we do end up going to 2D transgastric imaging because, as you saw before, that's really the way that we can see the leaflets in the valve the clearest and really get a good understanding of where those commissures are, where those leaflets are, and in that sense, what our device orientation is relative to the leaflets. I know I'm showing some really clear 3D pictures, but that's not always possible depending on the person's imaging windows. And typically, this transgastric window is going to be exceptionally clear. And then here, the trick is getting the device relatively close to the leaflets so that they're not really far away from each other. And then on the TE side, really trying to move back and forth between leaflet tips and then the device arm to make sure that we're happy with how our orientation looks, even before we've crossed underneath the valve. Our next step is going to be actually getting underneath. And this can be done in lots of different ways. I'm just showing you the workflow that we currently will follow in our lab. Because I'm already transgastric with a TE probe, we'll actually get a 3D volume from here, and then we'll set up an MPR that gives us, again, the same 3 views that I've been describing from the beginning. Here, the order is just slightly different because we started from the short axis view. That's why it appears on that top left. But how you set it up doesn't really matter as long as the lab communication is consistent. And we like doing this because as we're crossing, we can understand how deep we are in the ventricle, make sure that our trajectories and our position haven't changed at all. And then this gives us really the advantage of being able to very closely monitor the orientation as well as we're crossing. The next step from here is going to be grasping the leaflets and getting good insertion. So this valve you see here doesn't have really large gaps in it, but that looks very, very repairable. And then when we're actually doing the leaflet grasping, in this case, we'll do sort of simultaneous grasping as opposed to one followed by the other. You can do this again in multiple ways. Our traditional workflow is going to be always to use a combination of ICE and TE imaging. And here you're seeing that we're using actually biplane ICE to get a good grasp. And you can see the visualization here is really quite exceptional. And we've done some optimization with some left flex on our ICE catheter. That's what's giving us really good imaging planes, both in the primary and the secondary imaging planes. So you can really have good confidence that there's excellent leaflet insertion before you put your clasp down and actually close your device. On our next slide, we're going to see what that potentially looks like if we use a 3D workflow. And in some people, when you have really great imaging, you can actually do the entire grasp from 3D MPR. And I like doing this because, again, as opposed to in biplane imaging, we have the additional short axis plane and the 3D plane. So this is particularly useful, especially if we're doing independent grasping. Like in this image here, you see we've grasped that lateral, which in this case was the anterior leaflet, and then we're going to get the septal. And then having that short axis in the 3D view is really useful because as you're doing that septal lateral movement, if you're having some device translation anteriorly, posteriorly, you can actually correct for that to make sure that you're not going to cause distortion on the valve. And so if the imaging allows, again, this is often a great workflow to stay in for even this part of the procedure. Moving on to our next slide and the next step. So once we know that we have the leaflets grasped, we'll usually go back to our transgastric view because this is a really good view to understand that leaflet insertion. We make sure those edges really are at the center of the device. And then we like to actually close in this view with usually color compare like you see here, because this gives us a very good understanding as we're closing. Are we causing some degree of distortion on the valve? What's actually happening to the color? And are we causing, again, new or eccentric jets of color? That's another hint in terms of distortion. And then from here, I'm not going to go into details about, how we evaluate the residual TR. I think Nadira will go into some of that. But obviously, we'll look in different windows, and we have a multi-parametric approach to understand, is this reduction adequate? Do we need to put in an additional device? And what are our next steps? And if we do want to do additional devices, then we'll basically repeat all of these steps, except for introducing the guide, but we'll again still make sure that we're starting from the mid-right atrium. Moving on to, I believe it's my last slide here. So hopefully that was a relatively clear, practical walkthrough of what a case looks like from sort of beginning to finish, along with some of the imaging, I guess, tips and key views that we're using. And really, if we think about tricuspid repair in this way, it's, sometimes considered a complicated procedure, but it actually can be distilled down to some very, very clear steps. And at the end of the day, the most important thing is really monitoring all those key features that we want to know at every point, in particular, our position, trajectory, orientation, and then making sure, obviously, we have excellent leaflet insertion so that we don't have something like an SLDA or anything else. And as you saw in this case example, using all of those imaging tools, including 3D MPR, lots of transgastric views, 3D ICE if you have that available to you, are strongly recommended. Thank you.
Great, Edwin. Thank you so much. That was awesome. We'll maybe take two questions from the audience quickly, just to keep things moving along. The one is people are asking about the use of 3D ICE versus TEE for intraprocedural guidance. I mean, what is your advice to people doing tricuspid intervention? Do they need to have ICE? Can they do these procedures without ICE? Can they do them ICE only? Just maybe share your thoughts, Edwin.
Yeah, so my quick take on it is, when you have really great TE windows, I mean, you can do the procedure very quickly and efficiently and well with TE. Where ICE is really, really helpful are when those TE windows are not so great, especially at that leaflet insertion step when you really want to be sure. Our workflow has been to use ICE, for most of our cases. Actually, for repair, we use it for all of our cases because there's a bit of a learning curve with that as well. And you don't really want to have to take it out and use it for the first time when you have really difficult imaging windows. So I personally encourage people to learn on all of their cases until they're very comfortable. And then you can pick and choose when you really need it or when you don't.
Right, great. There are a few other questions, but I think some of them you guys are going to answer in your presentation. So, Nadira, if you don't mind, we'll go to your presentation. And Nadira really is going to give us a masterclass now in imaging for tricuspid valve intervention. Go ahead, Nadira.
Azim and the entire directors of the TIO USA, congratulations on the well-run virtual platform. I love this meeting. And so really that masterclass, when I was given this talk in 12 minutes, it's a lot, but I will do my very best and to cover as much as possible. Next slide, please. I don't think my marker is working. All right, these are my disclosures. Next slide. And so really the first part at a divided into the 3 parts. The planning is so important, as you heard from Edwin and also from Firas as well. Next slide. And so the big 5 for success. Next slide, please. So we have, in terms of the anatomical, as illustrated by Firas. Press next slide. Apologies for that. I'm not sure why it's not working as I forwarded. These are the 5 things that I think, which I told a lot of my fellows in terms of really for anatomical success, in terms of the gaps, the anatomy, the leads, the imaging windows as highlighted by Edwin as well, the use of ICE as well. And not only forgetting about just the tricuspid TR and the annulus and the leaflet morphology, I think during the planning processes, you need to look at also the right ventricle, the left-sided presence of any valvular disease and only pulmonary vascular vasculature as well. Next slide. And the mnemonic that I use for this always for in my current practice, Galileo. Next slide. And so, as Edwin has highlighted, and the key thing is the RV inflow outflow view for planning during TE. If you can't get it in the mid esophageal view with color and no color, next slide, please, you can always use the distal esophageal views. And this is really key to really appreciate, as Edwin has highlighted. And this is applicable not only for the TIO therapy, but also importantly for the replacement technology as well, as you're looking for the evoke, the leaflets, and the annulus as well. Next slide. Now, the transgastric, as what Edwin has highlighted, really, really key. You need to be at the leaflet tips. So my key, I love to do the RV inflow outflow on the 0 degrees and then moving forward to 90 to know that you are really truly at the leaflet tips, as you see on the right-hand side when you biplane it. Next slide. And so here you can see at 80 to 90 degrees, the RV lead really in the posteroceptal leaflets. And you know the jet is all around the lead leading to a CIED related TR. Next slide. And so, as Viras has mentioned, the predictors for TIO therapy, the Galileo is really applicable, the gap, the jet location, imaging quality, the caudal structure, and the on-force morphology. And we have moved really looking at all these parameters just based on TE to guide us between TIO or replacement technology as well. Next slide. And if we think that we cannot reduce the TR down to mild, we are thinking of a replacement technology. And that's where CT really plays a huge role. And the utility of CT is not just about the perimeter, not just about the perimeter of the valve, but we look at the RV, we look at the papillary muscle, all these caudal structure as well during the analysis of a replacement technology. And it's really key for your planning purposes. Next slide. And so the evolution of cardiac CT in TR, really key. You really need a dedicated CT for this TR in terms of the bolus tracking. You want to ensure that the right side is truly highlighted, and analysis of it in the RV 4-chamber, 2-chamber, and 3-chamber as well, and the reconstruction of it, certainly with the timing and bolus tracking as well, to really ensure that both the RA and the RV is well highlighted. And as this is measured, especially in the replacement, the different technologies or replacement technologies. Next slide. And so the CT is used not only just the annulus, the RV, the RA. We look at the IVC trajectory of the different catheters and the technologies to attain the certain height of the patient, so we can determine whether the axis of it is it the right or the left side as well. And especially for challenging anatomies, if it's not suitable, we are thinking as well the transjugular as well. And CT is really useful for these purposes. Next slide. And so in addition to that, if the echo in terms of analysis of your RV is not adequate, we have used a lot of our CT and to show whether the RV function as well, to determine whether we should redo a repair or replacement technology. And it's really key to appreciate the RV function. And in certain cases, obviously the gold standard cardiac MRI can be used. Next slide. Next slide, please. Thank you. And another, next slide. So this one, you can see that courtesy of Dr. Cavalcante, we appreciate with really 3D reconstruction, and we can get truly the transgastric view based in the CT. You can see on the right-hand side, the similar case, you can see the pacing lead in the AS commissure. You can see that significant PS gap in the posteroceptal, and this is a quadricuspid valve. Large gaps, we can see the prominent eustachian valve, and certainly the utility of CT to even guide TIO therapy at the beginning to know leaning towards replacement technology can be certainly used with this endoluminal views of the tricuspid valve. Next slide. The role of cardiac MRI I've highlighted in terms of the RV function as well, and also in terms of severity of TR. The technology now has really evolved, and if there's any discrepancy, we tend to use cardiac MRI as well to determine the severity of the TR. Next slide. Now, in terms of intra-procedural, I know a lot of the has been spoken to by Edwin and also Mark Russo, but I'm just going to highlight key points of a couple of cases in terms of guidance as well. Next slide. So this is a case you can see, a patient with a severe tricuspid regurgitation. Certainly similar, you can see the RV inflow alpha view and the transgastric view. Next slide. Next slide, please. And so Edwin highlighted the 3D MPR. This is a live 3D view as my interventionist would steer down the catheter. Next slide. In addition, 3D MPR certainly is very helpful. And this case, you can see from the distal esophageal view, as Edwin has highlighted, is really very challenging to determine the septal leaflet in terms of the insertion. Next slide. And so we use a lot of 3D catheter, and we switch to 3D ICE catheter and utilize the 3D navigation, which a lot of us in the panel have pioneered it as well, and really help to efficiency of the 3D ICE catheter. And as Edwin has alluded, the learning curve of this and speed track our workflow process during the procedure. Next slide. So you can see that with the 3D navigation, we have clear illustration of the leaflets with insertion into the clip arms. Next slide. But one key thing that I've learned and we have learned as a team that not only dependent on the 3D ICE, we go back to the TE looking at the transgastric view. And as Edwin has shown that you really want to have that two leaflets in the middle of the clip. And really we gotten caught by this and we need two confirmatory views. And you can see that septal leaflet is not in the middle of the clip. And so we went back, next slide, in terms of optimizing the septal leaflet. And we went back again, repeat the steps from transgastric view and also the ICE as well to really optimize that septal leaflet. You can see on the right hand side really the septal leaflet being taught. So these are the key things to really highlight during the TIO therapy to make sure that as an imager and communication to the team as well, what is your concern, and really ensuring that both leaflets are within the clip arms to avoid that SLDA. Next slide. And so similar, again, repeat the steps for the second tri-clip. And in this case, we're putting in an A-frame, a clover type. Next slide. And using, again, 3D ICE, 3D navigation, you can see orientation of the clip from 2 to 4 o'clock in the posteroceptal region. Usually in this phase, the TE can be challenging with the views for your biplane grasping view. So we utilize the 3D and 3D ICE navigation. Next slide. And so once we confirm, we can see on the right-hand side, clear illustration of that both the leaflets, again, of the second clip within the clip arms into the clips. Next slide. And we gotten a good result for this patient with really like mild tricuspid regurgitation. In terms of quantification, during the case, we always use 3D VCA, 3D color Doppler, and really measure it on your 3DQ to really get a true quantification and down in terms of percentage reduction down to mild 18 millimeters for this case. Next slide. And so that case was really highlighting what we need to do as an imager and really to master that TIO therapy. In terms of TTVR, similarly as well. Next slide. And so this is a case, I probably presented this before, but really I love this case because this is one of the cases with a lot of leads. This is the real world where you cannot see the leaflets at all. And this is a patient only suitable for TTVR. And we placed this patient with Evoke. Next slide. And you can see on the CT, I said this next slide, please. This patient has like 5 leads and it's like a spaghetti on the bottom left, but we found a trajectory. But on the TE, it's impossible for me to have that little spot, and suddenly my IC used fluoroscopy to go through that direction. And next slide. And really for this case, 3D ICE has changed in terms of the practice for us in terms of the TTVR, as pioneered by some of our colleagues in our field. So here you can see clear illustration of the anchors right beneath, and throughout that case, we use 3D ICE for this case with successful implantation of the Evoke with no PBL and no regurgitation. Next slide. But one thing that we have learned in Evoke is, besides the 3D eyes, the use of TEE still matters a lot. This is a case that we did just last week. You can see on the left-hand side, transgastric view. This is a patient who had a lead revision so that we can place the Evoke. And one thing on the arrow on the left-hand side, you can see the septal leaflet is so tethered. And 3D MPR from the transgastric view, you can see on the middle row that tethered septal leaflet is plastered to the interventricular septum. And measurement on the CT was borderline, and so they thought that we could do the case. And so on the table, you can see measurement of this leaflet to the wall was barely 4 millimeters, which is inappropriate for us to anchor the anchors of the Evoke. And we confirm it with ICE imaging as well. You can see on the right-hand side, this is the new vision, the new generation, and confirm it as well. Really, if you can play that moving images, you appreciate that septal leaflet as well, really plastered with less than 4 millimeters. And so this case was aborted, and we proceeded with another TTVR. And so the last part of this imaging masterclass is really about follow-up of these patients. Next slide. And it's key that not just intraprocedural quantification, but the main mode of modality post-op and before discharge and in our clinic is really transthoracic. Really key to get good imaging. And in the TIO therapy, really evaluating the residual TR. Now, obviously, we should do this by 3D, but with transthoracic, it can be challenging in some of these patients to measure the 3D VCA, and we can get it in transthoracic. Certainly the gradients, and looking for complications in SLDA. TTVR, similarly, gradients, looking at the leaflets to see if there's any restrictions, the presence or absence of paravalvular leak, the leaflet thrombosis, obviously enhanced with CT. And if there's any clinical indication, if there is the restriction, certainly CT will give us a better definition of Holt or thrombosis. We all should measure the RV function very well in terms from the echo, from the apical views, RV focus view, use all modality. We have certainly utilized strain imaging as well, which is what we should always report on. And then CT as well for both the TTVR, especially as I mentioned. Now, if there's any indication, if there's significant residual TR, we will then move on to do TEE in terms of whether can we put another clip, or even like combination therapy, like what Firas has highlighted, and also for the TTVR, if there's any indication for any PVL, to do a TEE to assess for this. Next slide. And then this is in terms of imaging, and the key thing, we do 30-day CT for all our cases. And you can see on the left-hand side, the RV remodeling for one of our first few Evoke cases. You can see the pre on the top left-hand side, and certainly post that remodeling of the RV back to the croissant with improved RV function. Sorry, this images wasn't playing, but on the right-hand side, this is one of our patients with a triclip looking for complications, and during transthoracic indicated of a SLDA, and we proceeded with a TEE and showed that SLDA with significant residual TR, and certainly managing it with other transcatheter tricuspid technologies to treat this TR as he's symptomatic. Next slide. And so overall, in summary, the key points, important pre-procedural planning, quantitation, morphology, and the RV function as well, catering to the selection of devices, because we are in this era, we have an options of not a replacement and repair. What is the best patient, as highlighted by the previous speakers as well? Using all mode of modality, TEE, CT, MRI, 3D ICE, to think besides the TIO therapy, replacement technology, and not forgetting the role of heterotopic cable valve devices, if none of these are an option, or even the annuloplasty as well. And working with your colleagues, in our surgical colleagues, heart failure colleagues, and EP colleagues to optimize this patient. With that, thank you very much.
Thanks, Najira. That was great. I think for the sake of time, we're just going to keep it moving so we can get through everyone's presentations and hopefully do some questions at the end. I think we have Mark back. So, Mark,
Can you hear me?
looking forward to hearing your. Yes, we can.
Okay, great. I was asked to present a tricuspid, a transcatheter tricuspid replacement case. So I'll address some of the questions that came up earlier. Nick had asked about replacement versus repair for mitral transcatheter mitral approaches, and I would say my answer for tricuspid is the opposite. So although I prefer repair in the mitral position, for tricuspid we tend to favor replacement because quite honestly, I think that the outcomes can be more mixed and the procedures are technically more challenging. So if you're looking on a broader basis, then replacement is our go-to.
We can just, I mean, I think that makes a great point, Mark, and maybe we can just talk about that a little bit, and hear the panel as well, because that's been one of the most common questions that have come up from the audience is, this whole issue of repair versus replacement. And usually, from when you do surgery, repair is always better, right, than replacement for you maintaining the integrity of the heart, the valve. But when it comes to transcatheter, I agree with you. There seems to be a difference between mitral and tricuspid. Do you think it's just a limitation of the current technologies, or is it because our patient selection isn't great, or maybe just what we can do with the devices? Maybe, if we put more clips in, sometimes we'd get a better outcome.
Yeah, we were an early adopter of tricuspid clip. Going back to 2018, 2019, we were doing procedures off label. They're challenging procedures. They can take a long time. The case I was going to present was an Evoke case under ICE and MAC. It was less than a 50-minute case. I mean, from a technical standpoint, it is not a challenging procedure, right? I mean, if you can, and I would love to be able to show some of the pictures just to show the ICE images, because they were really beautiful images. And the procedure, again, it's largely an imaging procedure. The technical aspects of it are not challenging. So if you can get the pictures that you need, then it's a reproducible procedure where you can expect an excellent outcome. And you can imagine, everyone's looking for the next TAVR. I don't think that there's a next TAVR. I think mitral and tricuspid are way more complicated than aortic stenosis. So that hope, people should they need to separate themselves from that. But I do think the next closest thing is probably transcatheter tricuspid replacement. It's a very reproducible procedure. Again, technically, it's not challenging. It's about good patient selection and getting good pictures. And again, this was a case. This was actually one of our early ICE MAC cases. We had previously done general here. So here we go. We can go through this quickly in the interest of time. So this is just showing the device. It's bovine pericardium. It goes through a 28 French system. There's 3 anchoring mechanisms. There's leaflet anchors. There's also the expandable frame, and then the skirt also for sealing. In addition, you get some retention from the papillary muscles. In the case that I'm going to present, that's not relevant because it's really only where you don't have significant oversizing, which you did have here. You can move to the next slide. So this is just quick case planning. The main watch out here was that there was some plastering of the septal leaflet, so we had to be biased septally. But other than that, it was a relatively straightforward case. It was a left femoral access case because the RA height was less than 60. It was about 57. And again, the annulus had approximately 5% oversizing. Next. So again, moderate sedation, ICE, no TE, no intubation. We've actually gotten to the point where we've had some patients that we have to intubate just because they're so deconditioned in heart failure with ascites that they can't lie flat. And we still haven't been using TE for those cases because we actually find that the workflow is faster with ICE rather than going back and forth between TE and ICE, where you sometimes have to reconstruct the images, or you get interference. We find that the ICE images are just superior, and it's just more efficient. Next. So the setup, again, this was left femoral access, obviously bifemoral access, one for the ICE, one for the device. The one thing one little efficiency point that I'll say is that we usually resize the valve both in the holding area, and as soon as we get access, we put the ice probe in the RA to resize, and that can save you about 20 minutes. If you do a whole bunch of work to get to get access on both sides, and don't size in the holding area, then you've probably wasted about 20 minutes during the case waiting for to get the sizing and then device to be prepped. Next. Here's just some sizing images. Next. So knobology. One thing that is complicated about the device is the number of knobs. So there's primary flex, which is largely moves you from anterior to posterior. The secondary moves you from septal to lateral. There's also a depth knob. You can rotate the device clockwise and counterclockwise to get better trajectory on the device once you're in the RV. And then you have to manage the capsule and the stabilizer. Next. So this is just navigating the valve. It's to get RV access, we usually use an Agilus catheter and a safari wire, sometimes plus or minus a pigtail. Basically, you're just advancing the device and using primary flex to go anterior, posterior to get across the valve. The main trick is to make sure that your safari catheter is in mid RV. Next. You can see the ice catheter there. This is just an animation, so you can get a sense of the navigation of the devices and the anchoring of the system. So you want to create a capsule gap, and then there's a staged anchor flip. So you go from 45 to 90 full flip to capture the leaflets, and then full ventricular expansion. And I actually find the most anxiety-provoking part of the procedure is getting the device out through the valve. So here you see ventricular expansion deployment. And this is what it looks like in real life. And this is just a real life version of what you just saw in the animation, flipping 45, 90. And the key is, and I'll show some better images of this, of what the ice looks like. But you can see those are really great images. You can see the leaflets very clearly. You can see them falling on the device. This was, like I said, a pretty straightforward case and moved along pretty quickly. You can see more of a flip there, moving the leaflet capture. And that's what it looks like on fluoroscopy. If you move to the next images, there's a series of 3 images. So this is a close-up of the ice images. So this is using, you can just keep flipping through these after the heart stops beating. But this is using GE Pioneer system and New Vision. Again, you can really, I mean, I'm a heart surgeon, right? I'm not formally trained in echo. I just learned it from being in the room, and I can see what's going on here. Those are really some straightforward images. And as I said, for me, the most anxiety-provoking part of the case is getting the system out. So just retracting the tip, making sure that it's clear from the valve. It is possible to knock the valve off and embolize the valve. We fortunately have not had that experience, but I'm sure when we do enough cases, we will get the device out. And then if you just let this play through, you'll see the final images where we had a very good result. There was no leak. You can see the leaflets are moving well. Really beautiful pictures from, again, this is all ice under MAC. I think the keys for MAC are to have, when you start doing this, have some good anesthesia support, make sure that you're comfortable with the ice imaging and that the case moves along. Again, this was a case that took less than an hour. If the cases are going to take 2 or 3 hours, then it might change the model a little bit. But we've actually found that it speeds up our cases rather than makes them more complicated. And I think that's really the last image that we need to see.
Great. Thanks, Mark. There was a great demonstration of a case. Are there any cases you won't do with ice where you'll say specifically, actually, this is not a good ice only case?
I mean, I'm sure that will come up, but again, we've just found that it just speeds the workflow. You're not negotiating going between TE and ice, and having to reconstruct and having the interference from the system. It's hard. Edwin's pictures were so beautiful. I'm sorry, Nadir, I missed a lot of your presentation, but I see those images and I think, well, it's hard to do better better than that. But I think it's similar to TAVR to some degree, where we did GA for a long time. We had a great imager, and someone would show us great pictures during TAVR, and so we were a little hesitant to step away from that. But it is a lot on the patients to intubate them. You put a ET tube in, a TE probe. Some small percentage of patients are going to knock out their swallowing mechanism. If they aspirate, that's a real thing. And again, I think it's just it just speeds it just makes the case more efficient. Every center is probably a little bit different, but for us, we've really I think it's been a great success, this shift.
Do you
Right,
still have your
right.
echocardiologist on the console?
So we haven't been for those cases. We've done some M3 cases where we've done combined TE and ICE. I don't think that I would feel comfortable not having an echocardiographer in those cases. I don't think that we're there yet. And but for these cases, we had no dedicated imager. We have great anesthesiologists who are also great imagers. So if we were in a situation where we needed somebody to put a TE probe down and give us support, I would feel comfortable with that, and it would give us time to mobilize somebody to the room. But we've been doing the cases without without a dedicated imager.
So who's manipulating the console and the images? Is it the industry personnel?
No, we are. I mean, in full disclosure, it's largely my IC colleague. I think he's more adept at it than I am. I'm still at the steep part of the learning curve. I can interpret the pictures, but I don't necessarily. Again, I'm a heart surgeon. I'm not. I'm not a cardiologist. I'm not an imager, and I don't aspire or claim to be. I mean, it's a very specialized skill set. But my IC colleague, Ankur Sethi, he's very capable. He's a very good imager in addition to an interventionalist. So that's probably something I should also say, that it's you have to have somebody who understands. But the industry support has been great for us. But I think that you need, at the end of the day, as operators, you need to take ownership, and so you need to be able to build a team around this. And in different situations, that team might look differently in the room.
So maybe, Gagan, if I could ask you, I mean, in your practice, what percentage of your tricuspids are repair versus replacement?
I would say probably about 75% repair, 25% replacement.
Which seems to be a little different to, I guess, what Mark is saying, maybe even our practice at Monty. So, I mean, how do we balance this? Is it just, are we just terrible at doing TIA, me and Edwin, and that's why we prefer replacement? And we need to come to UC Davis and get some training? Is it just
That's
different
definitely true for us.
expectations?
Yeah, I mean, I think this is something we really need a true contemporary randomized trial. I think all of us who do take these patients, we clearly know who is a good TTVR patient. We clearly know who is probably a better TIR patient, but that big group in the middle, which I know you can do a fantastic TTVR on. If I have my good imaging partner with me on that day, I know I can do a great TIR on. That's the type of study we need, a randomized study, because there's clinical equipoise here as to what is not just acutely the best thing, but these patients, as we follow them out to year 3, 4, 5, what's the better strategy? And that I don't have an answer for you on.
Right. Okay. Yeah, I think the only way we resolve this is a randomized study, and I think that's, because, like you say, the patients on that house ladder graph that you guys showed, where are clearly better TIR candidates, the others that are clearly better replacement candidates, but there's a lot that could go either way, and we don't really know what's better, and it's a question of, I guess, how you balance procedural success versus risks, right? I mean, TIA is so safe, but also, I guess it gets me to this other question that came up from the audience earlier, which, how do we measure success in these procedures? Is success the amount of TR reduction? Is it symptom reduction? And do the two correlate together, or is there something else we should also be looking at? So, Nadira?
Thanks, Azim. No, that's a great question because, number one, you want to make the patient feel better. That's, it does from the symptoms point of view. Absolutely. TR reduction, absolutely as well. We learn from all the data. The lesser it gets to, and now for TIO therapy, and Gagani, please chime in. Like we are aiming to like down to mild, not even moderate anymore. And so really that patient selection to begin with, if we can get a good result, certainly TIR first. And so these are the kind of questions that we discuss at the valve meeting. And so from the symptoms to the TR reduction and overall, we have to think about the overall picture of the patient, that congestion, that other biomarkers that we can, as we've seen in other therapies as well. Congestion in terms of the liver, and all their renal function, and also their in terms of their BNP as well. So these are the things of biomarkers that I believe that from the Triluminate trial, and a subdivision of it, they are actually looking at that as well. Similar with other trials as well, where you can see that congestion really reduction. Whether does it impact mortality? I think we do need data on this, and certainly things that we can look out for in terms of the data and as long term in the future. The other point that I want to say is durability as well, right? In terms of the tier and TTBR. I think these are the things that we are looking out for as we are doing more and more of these trials, and more data is coming out soon. So there's so much more, Azim, I think, and everybody that we are looking out for so that we can really optimize which therapy is best for the patient.
I mean, we talked a lot about anatomy, right? But I think you hinted a little now. It's also about the patient. And we also need to take into patient considerations. And I guess one of the biggest challenges for me is the more elderly patient who has an issue with bleeding. And we keep saying, all these patients are an AFib, but more and more I'm seeing these 80-year-olds who had their LAA closed because of bleeding. And our next section is LAA closure, so I'm just priming us for that too. Um, but that patient now, to give them a replacement, you need to be able to anticoagulate them. And I think we don't talk enough about the patient variables and factors. So, Mark, I mean, how much does the patient, their age, their frailty, now you're making the procedure awake with a local anesthesia or sedation. So you take away one of the factors that I was concerned about in the past, which was general anesthesia, the D tube down for long periods in a patient who's at high risk of bleeding. What about these other factors like anticoagulation or the risk of having a pacemaker with replacement?
No, absolutely. So that's a huge thing. It's interesting looking at it from a surgical perspective. If I did a surgical tricuspid replacement, I would 100% put a pacer lead in the patient, because I'm just going to assume that the patient's going to end up in heart block. And that's not been the experience necessarily with transcatheter tricuspid replacement, but the rate is still high, and the anticoagulation issue is real too, right? I mean, you're selecting patients who are already considered high risk for other things, and you're committing them to anticoagulation, and that needs to be a real consideration. So for me, I mean, it is weighing those two things. It's just we've favored replacement at this point, because I just think that we get a more reliable result, even in the setting of those other things. But in a world where repair is as effective as replacement, and it may be, again, the question's not answered, but for all those reasons, it should be better, right? 'Cause the risk of pacemaker is negligible compared to what it is for replacement, and you don't have to anticoagulate the patient. So it is, I mean, those are huge issues that we need to consider. But at the same time, I think that in our experience, just the results have been better. So that's why we favored it. But it's not to dismiss those other things, which are real concerns.
Yeah. Thanks, Mark. Edwin, there are a few questions from the audience about novel imaging and new imaging techniques. We talked about ICE. Where do you think the role of fusion imaging is? And then maybe even, what do you see in the future? Are there going to be AI supported imaging, robotics? Maybe, give us your thoughts about novel imaging techniques in the future.
Yeah, absolutely. So I think the imaging field is now rapidly evolving, and some of it's because of the demand that's been placed on it because of these transcatheter procedures. So it's actually really nice to see from the imaging side that, okay, now we're getting these technological leaps And I think, as you mentioned, I think some of those fusion and AI technologies are going to become play a much bigger role in what we have to offer from the imaging aspect. I mean, already, a lot of centers are using Philips Echo Navigator, like we are, which is the Echo Fluoral Fusion, and now they've just added AI assistance on the mitral side, specifically for mitral repair. That allows for some device tracking features as well. And I think that's going to quickly come to the tricuspid. I think there's also going to be probably a lot more live tracking via the echo, that even like in the Evoke case that we saw, is going to give us a much clearer idea of, where that annulus is. And from a fusion point of view, where that is on fluoro, where we can very, very clearly see the catheter and our capsule gap. And just having that sort of merge between the two, I think is going to be key. There's new ICE catheters that are sort of on the horizon as well that I think are going to continue to improve that type of imaging. And then the AI around that, and again, maybe even auto MPRs, things like that, I think are also going to be coming. And then lastly, you mentioned the robotics. I think there are some companies also working on robotic imaging solutions, whether that's with ICE or with TEE, which I think are interesting too, because potentially that can help more centers be able to perform complex imaging. Maybe it also helps us a little bit on the radiation protection side of things. So we'll see how that all plays out. But I think the future looks very bright for imaging.
Yeah, absolutely. I mean, I just saw recently an AI technology that they're looking at ICE, and we saw how great the images are from Mark. But imagine now if the AI every time just automatically showed you on the screen all 9 anchors, right? Like from 12 o'clock all the way around, because the AI could potentially do that. You could have it just select that picture all the time and do a quick spin and just show it to you, all right? So you wouldn't be manually going around. You just have it on the screen every time you press a button. So there's a lot of, I think, cool things that are happening, but it's about time. I think you're right, because the imaging part got left behind, I feel a little, as far as innovation goes. It was all about devices. And then suddenly we had these great devices and we didn't have the tools from an imaging point of view to implant them. Guys, this has been a great session. I wanted to thank all of you for your contribution, for your expertise. I'm sure the audience learned a lot on tricuspid and how quickly the field is moving. Your presentations were fantastic and great discussion. Mark, thank you for persisting through all the technical challenges. And yeah, I wish you guys all well for the weekend. Enjoy the World Cup. Enjoy the Knicks and the Spurs playing, and have a great weekend. For those of you who are still staying on to watch, we still have a great LAA session coming up next. Thanks, everyone.
Thanks, everyone.
Thank you.
Have a great day.